in relation to this assessment is that prior to starting the actual vital checking, there's the aspect of asking the assessor the urine output and the blood sugar, and asking the patient bleeding and rashes. Then you do your vitals. After vitals, then there's the part of reporting to the assessor. But you are reporting, you are just next to the patient but talking. All this usually happens in the same setup, and nowadays it's good because you just have one assessor and you are just within the same room throughout. So there's the bit of reporting to the assessor, the A to E: airway, breathing, circulation, disability, and exposure. With all that, you will be good to go. Should you miss anything, then that's the time now you can recollect and assessor, I forgot this and this and things of that kind. But ideally, by that time, you will be done. I think I've exhausted all that are included in Osce new assessment. I would like maybe somebody to interject if there's any issue. I can see someone asking about the patient exposure. So exposure, you will only concentrate on rashes, bleeding, and temperature. So temperature, by that time you would have taken the temperature of the patient, so you know. Then you would have asked about rashes and exposure. Remember, the marking criteria is saying that assess your exposure without exposing the patient, and that's why you are asking the patient whether they have any rashes, any bleeding, and things of that kind. Okay, any question? I can see also another question: do you have this on your YouTube site? I'll upload just the recording that we've just done today, and you will get a link to the same. Then within the week, I'll do now the actual assessment, where uninterrupted, without illustration, just a simulation of what is expected of you with an actor. I'll do that one, then I'll post it on the same. But there's a recording of all this that you will get in my YouTube channel. Okay, that's a good question. Any other issue? Now the new score. What are your score from your end on the patient I've just cleared? I had 32 respiratory rate, 97 SpO2. Air is air. I have air for breathing. Blood pressure 150/80. Pulse rate is 77. Consciousness, I have alert. Temperature 36.8. What's your score from that side? You can pop your answers in the comment section. But definitely don't worry, for the news chart, it is marked where you will write your recording. If it is within that range, you will just see the score that you will provide, that will be there for you. Now, for respirations, my patient had respirations of 33. 33 is above 25. So the new score there for respiration alone is 3. Yes. Are you agreeing with me? Yes. Then for SpO2 97, that's score 0. Air is 0. Blood pressure, we only score the systolic blood pressure. Okay? You don't score the diastolic. You score the upper one. So here we have 150, and 150 is falling under 0. So that is 0. Under pulse, we have 77. 77 is also 0. Under consciousness, we have alert. A is 0. Then temperature is 36.8. That is 0. So the news total for this patient is 3. Okay? the news patient for this, the total news score for this patient is 3. And that's where now you are again tripped, because when you have a news score of 3, ideally state that a news score of 0 is monitored 12 hourly, okay? A news score of 1 to 4 is monitored 4 hourly, okay? And things of that kind. 5 to 6 urgently, but 5 to 6 is monitored 1 hourly. But if there's any 3 in any of the parameters, you monitor the patient 1 hourly. So like in this case, the patient is having 3 on respiration. So this is a patient you will monitor every 1 hour. Yeah. And you will escalate. So under escalation, you will put yes. Yeah. And the news total is 3. In the old Osce, you would write the frequency of how you are going to monitor the patient. Yeah. And again, the assessor will also listen to the frequency you will provide. You will tell this patient that, Jason, I'm going to monitor you every 1 hour because of your respirations, yeah, and things of that kind. So you have to take note of such. As far as the news score is between 1 and 4, it is just 3 on one parameter. So you won't monitor 4 hourly but 1 hourly. I think that answers the question of how we calculate the news score. The other time, somebody has just asked me to elaborate on PHQ-9. Now, the other time we postponed this meeting because of elaborations which were to wait from the Osce team that usually train nurses. And there were considerations whether we should fill the PHQ-9, the candidate should fill the PHQ-9 themselves or the moose chart by themselves. But as per now, we assume that you will be provided with a PHQ-9 form that is already pre-filled. The only thing you will do is totaling them down there and having your final PHQ-9 score. Now, with the PHQ-9 score, usually it assesses for the risk of depression. Yeah. So usually the discussion you will have with the patient under assessment will revolve around their mood. Maybe they are grieving, involve the family members, refer to the mental health team. You will ask the patient, how do you feel about me referring you to the mental health team and things of that kind. If you refer to the assessment for PHQ-9 that is in my YouTube channel, you will see exact things we ask about PHQ-9s. It's still the same for both Osces. Same to most, you will find a pre-filled form. Your case is just to add the totals, then say this patient is at risk of malnutrition. Yeah. Then now you discuss things related to risk of malnutrition. With that one, you will be good to go. Is there any other question?
Yeah, can you make this clarification? I didn't get you well. Concerning the PHQ-9.
Yeah.
You said the PHQ-9 form will be given to LDPO.
Yeah.
Does that mean you're not going to fill it on by yourself? It's going to be filled by the examiner?
Usually the PHQ-9 form has several sections. I think there are about 9, and they illustrate either 0, 1, 2 and things of that kind. Yeah, so you just total them. That's your role, and that one you do during your recordings. The moment you are confirming your respiration and all that, when you are done, you also come to the PHQ-9, do the total. Now when you will be reporting, yeah, to the patient and the assessor, then now you will be telling the patient, I'll monitor you, I assessed you, and all your vitals are within the expected range. However, I have a concern about the PHQ-9 which we evaluated you with, showing that you have a score of 16, yeah, and this one shows that you are at risk, or this shows a provisional diagnosis of depression, yeah. So we will have to monitor you every 1 week, yeah, concerning that. It will depend on scenario, because for PHQ-9 is usually either home based and things of that kind, yeah. I understand, and that you discuss after sitting down. Can I sit down? We discuss this, yeah. I understand you are grieved by this, yeah. How are you faring on, yeah. Discuss all the things that are surrounding this issue. So the issue of pre-filling, they're only filling the parts because those things might be tricky for a student to capture all. And remember, the 20 minutes are also limited. It is time bound and things of that kind.
So you are saying that the form you are going to fill, either news or most or PSQ now, will depend on what scenario you're being given the assessment.
Yeah, all of them depend on the scenario. Another thing I've not illustrated is that, from my understanding, the current new Osce, you will use the news chart for all these scenarios except GCS. Yeah. Initially, we used to have a separate chart for MAST and the PHQ-9, but now you will do news plus the PHQ-9, the MUST. It's only the GCS that you will have a different chart, which is not news. Yeah. Any other question?
I have a question.
Yeah.
Okay, my question is this. How is the question going to look like? Is it going to be a written question, or someone will be there, or it's going to be displayed on a screen?
Pardon?
Hello, did you get me?
No, I didn't get. Kindly just repeat your question.
The question, is it going to be displayed on a screen, or someone will be there to read out the question to us in each station?
Oh, sorry, I forgot to illustrate one thing. I think it will answer your question and you will tell me whether it's answered. You will be provided with a scenario booklet, yeah, at the beginning, stating your scenario. So and so came in with this situation, the background information, medication, yeah, and things of that kind, yeah. So initially we used to be given 5 minutes to read through all these things, yeah. Right now there is no 5 minutes separate. However, within the 20 minutes, you are supposed to capture the most important information from that booklet and start your assessment straight away. So the tip is know where to locate the most important information about a patient. Know where they came to the hospital. That's most important. Any underlying conditions, any medications they're having, and social history. Are they living alone? Are they grieved, or do they have issues either smoking, drinking, and things of that kind, so that it will help you in your health education at the end of your presentation. Yeah. And that one will also give you more information on what to look for, because as you are doing your assessment, you are preparing for your planning. So all the information you gather, that's what you will use for your planning. Should you fail to ask any question, you won't pop it in your planning. Let's say the patient said she's not in pain. Should you write pain as one of your care problems, you are down. So the question or the scenario will be provided to you in a booklet. Just peruse over it very quickly before you kick off and get information about the scenario. At the same time, The assessor will give you some minutes, confirm whether all your things are in the right place. Get note to have a glance at what's in that booklet and be a quick reader, capture very fast what is expected of you. Should you fail to capture it, you can also capture it along as you will just get to know your system. I don't know, Hattie, if I've answered your question.
Yeah, you did. Thank you.
Okay, that's fine. Fair enough. Any other question?
Vincent, in the assessment, you're not going to conduct your Osce with a live patient, right?
You are going to interact with a live patient, an actor.
Oh, wow.
Yeah.
Okay.
Yeah, so that's one thing you also need to know. You are going to have an actor, and an actor, they are trained actors, so they will act according to the scenario you are provided. You see, in the patient we've just concluded, the patient had a respiratory rate of 32. They will demonstrate that they are breathless during your assessment. Yeah. So the moment, and they know actually how the assessment flows. They are very smart. Yeah. So they will just be okay. Then when you tell them now, I'll be checking your respiratory rate, then they will be breathless. Yeah. Yeah. It's your duty to capture the respiratory rate and determine that they are breathless and act humanely. I can see you have a problem with your breathing. Can I sit you up a bit? Things of that kind. Recognize the problem the patient is having. So yes, you are going to have an actor. If the patient is a PHQ-9, they will be very confused and they will keep on interrupting you. Yeah. If it's a most patient, they will know exactly questions to answer, and if they are not able to answer, the assessor is usually following closely the questions you are asking the patient. If it is beyond them, they interject. Yeah. Things of that kind.
Though I'm not sure, I thought in the old Osce you are going to be given this course, the vital signs course, by the examiner. It is same in the new Osce.
You are going to be given?
I thought that's what I had. You are going to be given the pulse, temperature, and BP scores.
So that one used to happen during COVID. Yeah. When there was that lockdown and all that, there was the need to prevent. It might come in with the changes that are coming along with the COVID cases rising and all that. But as per now, you are going to have an actor and you will obtain your own readings. Yeah. And like, even when we were doing our Osce, we used to be given the values. Yeah. But the actors came in and now we had to obtain the values. So be ready for an actor and don't be surprised. Don't fear them because they are trained, so they know what they are doing and they're just there to help you. So recognize their problem. Any other question?
And one other thing, you are required to take the pulse, respirations, blood pressure, and all this. Are we going to chat while we're taking, or we have to take all the measures and then at last we are going to fill the template?
Okay, that's a good question. I consider that to be person-to-person basis. When I was practicing, if I write my vital signs separate, yeah, I use one to forget temperature, yeah, then I would run out of time. So I decided the moment I'm going to do my recordings, I go straight away, record them, then I'll know exactly what is remaining. But that one comes with a risk of wrongly charting them, yeah, which now will be heavily penalized. So other people prefer writing them down separate and providing them keenly when they have the time. It's only that should you fail to transfer them at any given time, that's a fail. And that also applies with those who have resorted to write them directly. Should you write in a different box, that's also a fail.
You talk about A, B, C, D, E.
Yeah?
You talk about A, B, C, D, E, right?
Yeah.
And you said it's part of the assessment.
Yeah.
So, what do you advise? Can we, I know those questions would take time, would take much of our time. Maybe we cannot have enough time to do the vital signs and all this. So, what will you advise? Can we dwell more on it or just take verify information about the ABCD?
So, what makes the old Osce and the new Osce different is the ABCDE, yeah? And according to me, I've just provided a better outlook or format on how you can go through it without getting confused. One thing key for the Osce station is be systematic, yeah? So get in there, introduce yourself, and after getting to know the patient's allergies and pain, ask them any exposure any rashes and bleeding. Yeah, confirm with the assessor if the urine output is okay, the blood sugar is okay. Yeah, then do your vital signs uninterrupted. Yeah, then prove to the assessor that you know what ABCD is by reporting that. Assessor, in terms of airway, Jason is having a clear airway and there is no blockade. Yeah. In terms of breathing, the respiratory rate is 37, having mild distress. You will just find your wording, yeah? Or is having a respiratory rate of 17, there's no distress, there's no use of accessory muscles, and while doing that assessment, I checked for both depth, rate, and rhythm, and there was no problem. In terms of circulation, so you will be using the word in terms of, so that assessor should not assume that you don't know any of those portions. In terms of circulation, the blood pressure is 150 over this, which is within the expected range. The pulse rate was 86, within the expected range. Yeah. In terms of disability, my patient is alert and is oriented to time, place, and person. Yeah, because we are able to communicate throughout. The urine output is satisfactory. The blood sugar levels, depending on the report that the assessor gave you, the blood sugar levels is 7.2, and that's within the expected range. In terms of the exposure, my patient is having a temperature of 36.8, yeah, and is having no rashes. There is no bleeding, yeah. With that one, you are good. So that provides a systematic way of presenting your findings. Yeah, I think that would work for us. Yeah.
And one other thing, on the news chart,
yeah,
respiration comes first, oxygen saturation followed by blood pressure, then pulse, and then the alertness, temperature of the patient. So those, as it comes in this format, are we required to take the vital sign in this format, or we can start with any? Let's say we can start with blood pressure or pulse or anything that we wish.
Okay, in terms of the order of the taking the vital signs, there's whichever side you start with it will be upon you, provided you've assessed all the parameters. Yeah. And now, the reason why we do like starting with the blood pressure and all that is, you can do blood pressure, SpO2, and temperature at the same time, then record them. Yeah. By the time you will be taking your temperature, the BP and the SpO2 is already read, so you just note them down. Yeah. And that one saves you time. Then you move to the 2 minutes of respiration and pulse. So it doesn't matter the order, provided you do all the parameters provided. And that applies to even GCS. Remember, GCS now, there's the other aspects of motor, eye, and things of that kind. So it depends. Which one would you prefer starting with, provided you don't forget any bit? Okay, I can see ranges of vital readings given to you since respiration, temperature, and BPs normally vary. Yeah, the ranges are provided in your news chart here. Along this line, there's the expected ranges, yeah, or the ranges that are provided, and they are marked in terms of white, that is normal. In terms of a bit of yellowish, that is 1. Then we have then we have orange for 2, then indigo for 3. So you will know which one is not expected and things of that kind. So the ranges are here. You will be able to know the exact one you want.
So I have a question.
Yes.
Okay, I don't know if a sheet of paper will be allowed, maybe for us to jot our vitals before transferring it to the news chart. Is that allowed?
Yeah, you will be provided with a separate sheet of paper having the issue of assessment and things of that kind. You can use that one because it's not usually marked. For the assessment, this is the only paper that is marked. So the other papers, any of them, you can use to record your findings, but they won't be marked.
Okay, thanks.
Yeah. Any other question? Okay, I think with that one we cover various aspects of Osce assessment and also the questions you provided. And I don't know if any of you have anything that is pending for the assessment. For the assessment, just know that it's an easy session. You just need to be systematic so that you don't confuse yourself. Then what usually, the blunder that most people usually make is poor recording. Yeah, so know exactly how you are going to make your recordings, whether you will jot them separate or straight away on the paper. Yeah, the one that fits you. I can't recommend any because what majority were using one was not working for me. So definitely it's person to person basis. Yeah, people opted for writing them separate, and I tried that one and it never worked. So I wouldn't recommend any of them because it would be person to person. You can do practice with either of them and see the one that fits you, and exactly that's what you go and use. Yeah, and be malleable so that you can be able to adjust any other thing, any disruptions that patient brings along. Take good care of them. If a patient complains of something, recognize that that thing. Maybe the patient is asking, who will feed my dogs? And maybe is a confused patient. From your history, you should know either they are living alone, they are living with the daughter. If they are grieved, maybe she lost the daughter, and you are like, should I tell your daughter to come in? And the assessor will be like, you want to bring back the dead person. Yeah, so you should you should know the background of your patient. Yes, Owate, what's up? You can state your question.
Good afternoon.
Yes, good afternoon to you.
Yes. I put my question on the chat, but I was trying to ask if it's compulsory. We put all the charts, that's the MOST, the PHQ, and the neurological charts. If we use all of them in the assessment, because the assessment might not be able to accommodate all within, I think it's 20 minutes, right? So it might not be able to accommodate, or is it dependent on the symptoms the patient portrays? So that wanted to ask. Thank you.
Okay, thank you very much. Thank you for that question. The thing is for assessment, the scenario is what will determine which chart to use, yeah? And you will be only provided with one chart to use. You won't be tested on which one you are going to use, yeah? So you will only be provided with one. If it is news assessment chart only, then just know it's a news patient, yeah? If you have news and moose chart, then know you are dealing with a moose patient. If you have a PHQ-9 chart and the news chart, no, it's a PHQ-9 patient. If you have a GCS chart, then just know it's a neuro patient. So you won't be expected to do all the charts at the same time. So you don't be bothered of that, but also take note of your patient scenario. The patient scenario can state that so and so have had hiatus hernia and is being prepared for theater. That is a news patient and not a post-op, yeah? And is unlike so and so had hiatus hernia, had undergone surgery, and is now being monitored. That is a post-op. So the scenario will guide you on exactly which chart to use, and also in your mind know the exact patient scenario you are handling, because it will guide you nicely in your care plan without misunderstanding yourself or confusing yourself.